A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not being done. And those who already have plaques, we need to do something so that their plaques don't progress and they don't rupture. Now, I got to tell you about this, because there's a lot of misunderstanding about LDL. It is the damaged LDL. That's the problem. The macrophages don't devour normal LDL. They devour and eat up small dense LDL, which is abnormal LDL. If you have small dense LDL, then the next question is, why is my LDL small? What damaged it? That's $1 million question. Fasting. There are so many different mechanisms by which one can not only live longer, but live healthier. And you can come across all these different inflammatory pathways. And it's the endocrine, it's the liver. But there's one thing that touches all the mechanisms and improves them all, and that's fasting. Fasting improves you metabolically. It detoxifies you, improves your microbiome, because your microbiome is completely reset by fasting. 300% increase in the release of stem cells, your own stem cells. Not only that, they're yours, they know where to go, and their residence rates is very high. That means they go where the repair needs to be. Fasting has to become your fundamental way of life.
Dr. J, as a cardiologist, I want you to start out by explaining what plaque in the arteries actually is and how it forms.
Plaque forms inside the arteries. There's 3 layers. There's the outer layer, middle layer, which is muscle, and then the inner layer, which is the intima. Plaque is when that intima starts getting disrupted. So it starts growing either inward and starts narrowing the artery itself, or starts growing outwards. This is an abnormal process. A plaque can be thought of as a pimple on the inside of the artery. It is very complex. It's composed of bad fats, which is the small dense LDL, the abnormal fats. And there's an inflammatory reaction against everything that's in there, which is that abnormal fat. So there's T cells in there, there's B cells in there, there's macrophages in there. And then in reaction to all that, there's a cellular fluid that builds up. Just like when you get a pimple, you get a swelling inside and it's awfully painful and it secretes some fluids. There's some fluids in there. It's full of inflammatory cells. That's how we can tell that that plaque that this particular patient has is made up of soft plaque or calcified plaque. And we can get into that in detail. But basically, the long and short of it is it's an inflammatory process. It's reacting to something. And that something is what we are trying to do in cardiology. It's trying to figure out what it is and how we can prevent this. And we can talk about this, obviously. My job as a traditional cardiologist, when I first started, is to identify these that when they narrow the artery and they decrease the blood flow, my job is to go and open up those arteries and get rid of those blockages. So that's how I became an interventional cardiologist. But then plaque is so complicated that you fix one plaque, but there's another one and another one and another one. And we can talk about this and how I got into all this, if you mind.
Yeah, continue. This is great.
So basically, we were taught that, okay, you got these blockages and they have many causes: diabetes, high blood pressure, cholesterol. And I went in and I would stent them and put a stent in there, get rid of that blockage. And then 6 months or a year later, they would come in again with chest pain again, because there was a blockage in the artery. There's not enough blood flow getting through there. And when I would cath them again, there would be a new blockage. It's not the same blockage. The re-narrowing was rare. 80% of the time, it's a new blockage somewhere else in another part of the artery. So this became a problem. So then, when we went back and looked at the angiograms, we would find that there was a 30% blockage or a 40% blockage in other parts of the arteries, and suddenly those became 80 or 90%. So this raises a lot of questions in our mind. Why are you getting new blockages when I just stented one other one? So that's what brought me to prevention. We have to find out the source of why you're getting new blockages. So rule number 1, atherosclerosis or plaques are not a focal disease. It's a systemic disease. If you got it in one artery, guess what? You got it in every artery. And you may think you don't. When you do an angiogram and you put the dye in the arteries, you may not see that plaque in the wall, which is why we're going to talk about how to identify those plaques. Because if they're not inside the lumen, and when you put the dye in the arteries, you're not going to see the blockage, but yet there's plaque in the wall. It gives you a false sense of security. So you do the angiogram and you say, oh, yeah, there's just one spot only. Guess what? It's not one spot. He's probably got plaque in the rest of the arteries. You're just not seeing it. And not only in the heart, you probably got it in your brain and in your carotids and in your aorta and in your lower extremity. It's a systemic disease. So rule number one, plaque is a systemic disease with a local manifestation. So it may be a blockage in your LAD, which is the artery in the front. But if you don't treat this systemic disease, you have not done the patient a good service. Yes, you got rid of that one blockage. So the patient may not now suffer from the consequences of that blockage. So he's not going to get an angina or he's not going to feel pressure in the chest. But that is different from a heart attack, which I want to definitely talk about the difference between these two. So the first thing is that you need to understand that plaque is not a focal disease. It's a focal disease when it's hurting you because you're getting chest pain or pressure or tightness or heaviness because of that narrowing in the artery. But that's just the tip of the iceberg. When you look at it carefully, you have plaques everywhere in all the arteries. And then these plaques are already predicated, are inflammatory. They're full of inflammation. These plaques are not just passive fibrosis that people think it is. It's active, metabolically extremely active. So when I was a fellow, we would take a little wire and pass it down that artery and look at temperature changes as you go down past the different plaques. And some would be hot, some would be cold. That tells you that there's inflammation, there's heat in there. And then as time went on and we dissected these plaques and started looking at them, we saw that they were actually full of inflammatory molecules in them. So now what was happening with these patients in the history of my career is that they would come back with a new plaque, a new blockage. Suddenly it went from 40% 6 months ago to 80%. What happened there? Well, the plaque ruptured. So what does that mean? Well, what that means is that that plaque, which is like a pimple on the inside of the artery, suddenly cracked open and a blood clot formed on it. When that blood clot is a small one, the body will repair it and cover over it in the next few weeks. A couple of weeks later, it cracks again. And now you're going to get more covering over it. The clot on the inside gets resolved. So when the clot resolves, it leaves behind fibrosis. Just like if you cut yourself, you get a little scar on your hand. So these are scars. And these scars that are left behind get calcified. The calcium that's inside the plaque, because this is all going to be relevant to what I'm going to say later on. The calcium that's inside the plaque is related to the macrophages, which are white cells that die. And when they die in the plaque, they release the calcium, and that's the calcium that you see. So when you see all these calcified plaques, it is the graveyard of white cells that have died inside that plaque. Now, that plaque ruptured, blood clot formed on it, got covered over, okay? And then it retracts a little bit. It becomes fibrotic, calcified, but then it cracks again. And the cracking is related to inflammation. So remember, like a pimple, if a pimple is hot, it's going to crack. It's very similar to pimples on your face. You get 10 pimples, you don't know which one's going to rupture, but the one that's the hottest is suddenly going to pop the next day. So the inflammatory milieu within that plaque dictates which plaque is going to crack. And when it cracks, it's because the necrosis on the inside takes off the cap as well. So the cap of the plaque cracks on the inside of the artery. So now blood clot forms on it. Now, if you are very unlucky, that blood clot can seal the whole artery off immediately, all of a sudden. And now that's a heart attack. So unlike what you thought of maybe 25 years ago, that a heart attack is caused by a gradual narrowing of the artery and then suddenly the artery one day shuts down due to plaque formation, is wrong. That's not what happens. Heart attacks are not caused in that way. I mean, about 10% may, but 90% of the time, you're able to run up 5 flights of stairs one day, and the next day you're getting a heart attack, and you go inside and you'll find that you've got a 90, 95% or 100% blockage. And you say, how did this happen when yesterday I was able to do everything I wanted to do? Because you went from a minimum plaque, which was not causing any problem for you. You were getting lots of blood going down there. It cracked. This is very important. It cracked. And then a blood clot formed, and you suddenly went to 90% or 95% or even 100%. So a heart attack is caused by the big blood clot that seals off the artery. Unstable angina, that is when it goes to like 80, 90%, but it doesn't seal the artery off completely. But now you're getting chest pain all of a sudden. Heaviness, tightness. But I flunked my stress test, but 6 months ago I could do everything I wanted to do. It's because that plaque cracked, and now you got a bigger plaque. So plaques don't grow linearly. They grow in steps. Now, why am I stressing all this? Because the point is that if you do not want to get plaque, and you don't want plaque progression, and you don't want to suffer from the consequences of plaque formation and rupture, you need to know the cause of it. It's inflammatory. It's not linear. It's not just a scar that's growing all the time. It cracks, repairs, cracks, repairs. And it's all related to inflammation. What is your inflammatory status? And we are now becoming an inflammatory human being. That's why we're getting this. The body's reacting and you're getting inflammation. So we need to understand what plaque is. It's an inflammatory process. What is heart attack? What is angina? Now, I just want to say a couple of things about this angina stuff because most people don't understand this. If I give you a blockage right now in your artery, and let's say I give you a 70, 80% blockage in your artery, and you flunk your stress test because it shows up on your stress test that your heart muscle is not getting enough blood supply, 8 out of 10 chance you are not going to get chest pain. What? 80% of the time you're not going to get chest pain, even though you got the serious blockage and you failed your stress test, and then says yes. 80% of ischemia means lack of circulation, is actually silent. This is an eye-opener. See, we're not taught this initially in school because we're taught to, okay, go in, fix that blockage. But wait a second, there's so many people who are walking around with serious blockages. If I had to do a stress test on them, they'll flunk because there's lack of circulation. But they're not having chest pain. Some of them just get shortness of breath on exertion. Some of them, they just get fatigue and tiredness. So this is a real problem for us. And then the next question is, at what level of narrowing in that artery would you really start getting symptoms or decreased blood flow? Now, that's very interesting because you need a 70% blockage before you reduce the blood flow. Now, that's an eye-opener for you. So let's say you have a 50 to 60% blockage. Obviously, there's no flow reduction. So would you get chest pain? The answer is no. Would you get shortness of breath from it? No. So how would you even know that you got this blockage? And I just said a few minutes ago that a blockage cracks and suddenly causes a heart attack. So you can go from 50% to 90 or 100%, depending on your inflammatory condition, on your body's constitution, on your metabolism, on your toxicity, on your lifestyle, on your environment. Those are the things that are going to suddenly predict whether that plaque is going to rupture or not. You didn't even know about it. You didn't even know that you have a 50% blockage or 60% blockage in your artery. Had you known that there's a 50% blockage sitting there, you would do everything possible to make sure that that plaque does not crack. Because now you know what causes death and what causes morbidity is plaque rupture. That's the animal that you want to prevent. Plaques can form. They do form. If you look at elderly people, they're going to have plaques. But those plaques may not be occlusive plaques, so they're not limiting blood flow, nor are they inflamed, so that they are unlikely to rupture. So we'll talk about this in just a little bit. But the point I'm trying to say is that a lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing that they're sitting on this plaque. And there are ways to find this out now. We have the technology. We have the know-how. We know how to do this. It's just not being done. And so now, as I was becoming a more mature cardiologist, started realizing that, gosh, what I see is just the tip of the iceberg in my cath lab. And there are so many people out there that have minor plaques that don't even know about it. And we need to find those. And those who already have plaques, we need to do something so that their plaques don't progress and they don't rupture. So that brought me to another whole understanding about plaques, which is that it's not just the plaque. I know you asked me about the plaque, but there was part 2 to this equation, a blood clot. So there are 2 parts to this whole problem. One is plaque formation, plaque rupture. So that's all to do with the plaque. The next thing is your blood. If your blood is clotty, your platelets are very jittery, you're going to get a big blood clot. So it's just as much a hematological incident that's happening in you as it is an inflammatory process. There's 2 parts to this equation. So that is why we started paying more attention to the condition of your blood. Do you have clotty blood? Because if you rupture a minor plaque, you can get a big blood clot. So what are the characteristics of the blood that I need to be looking for? And now we know that we give patients aspirin. You all know about that because what does aspirin do anyway? What does aspirin do? It's an antiplatelet agent. So the platelets are what makes that blood clot mostly. So that's why people who get chest pain, they pop aspirin in their mouth before they get to the hospital. That artery is more likely to be open because that blood clot will start dissolving a little bit because it's an antiplatelet agent. So platelets are a huge problem in these patients, the platelets. And so are your platelets different from my platelets? Yes. See, we don't understand that everyone's different. Our platelets are different. They have a life of their own. So your platelets may be more jittery than mine. So you and I can have the same plaque. We can both rupture, but you'll get a heart attack and I won't. It may be related to my hematological condition, my platelet jitteriness. And that's related also to that big word, inflammation. So if you are inflamed, your platelets are going to be jittery. There's going to be more tissue factor in that plaque that's going to make blood clots. There's going to be more pi1 levels, which is going to basically make sure that clot is really, really big and it's not going to dissolve the clot. So the clotting part is extremely important. Remember I told you that when plaques rupture, you get a blood clot there. Now, obviously, each time if it's a huge clot, your step up is going to be much greater than if your blood was just a small blood clot. So you want small blood clots. You don't want these big ones. So when I see the patients, and when I treat them, I got to make sure that, oh my gosh, is his hematocrit too high? Does he have a hemoglobin of 19 versus having a hemoglobin of 14 or 15? Yes, all these factors are important because his blood is too thick and he's got hyperviscosity and he will have a large blood clot. That's why I tell these patients to get a blood donation every 6 months. I say, wait, Dr. J, I got a heart problem and you tell me to go give blood. Yes, because you will have a 14% reduction in a future heart attack in the next 1 year after donating blood. If you have coronary artery disease, go and give blood. Get your hematocrit down because that's one factor that's going to be important also, amongst other factors. So you see, it's a very comprehensive approach, but it's not just plaque, it's also the blood and the condition of the blood. So you need antiplatelet agents, you need anti-inflammatory approach. The plaques need to be evaluated, yes, for the narrowing and extent, and then you look for inflammation, in those plaques. So it's a very complex workup. So these days, if someone comes to me and says, Dr. J, I want a plaque analysis. I want to know about my plaque. Do I have plaques? I really need to know. I just had a nice baby and I want to know that I'm going to be okay, right? So what do I do? How do I see a plaque without going inside? So I these days order a coronary calcium score because that will identify that plaque. It'll identify calcified plaques. The coronary calcium score will not identify non-calcified plaque. So again, let me just backtrack a little bit here. There's two types of plaques you have. You have fatty plaques and you have calcified plaques. Fatty plaques will eventually become calcified plaques. So if you really want to know, you need to know both kinds. Right now, we don't have that general technology available to everybody to look at plaque analysis. If you do a coronary CT angiogram, then AI can calculate your plaque volume and characteristics of that plaque. So let's say a CT angiogram. What is a CT angiogram? CT angiogram is you put an IV in the arm, you inject some contrast. The contrast will go through the right side of the heart, then your lungs, then come into your heart. As it comes into the heart, the CT scan is done, and you can see your coronary arteries filling. Okay? And then the very fancy computer will take out all the rest of the stuff, leave your arteries alone, and then AI can look at your plaque and tell you how much calcified plaque you got and how much soft plaque you got, and give you a ratio. Usually, it's about 3/4 of it is soft plaque, 1/4 of the plaque is usually calcified in most patients. In the soft plaque, the AI can also tell you whether you have low attenuation plaquing. What does that mean? So, when an X-ray goes through tissue, depending on the consistency of the tissue, you'll get black, white, gray. So when you get very dark shadows, very dark areas in the plaque, that's called low attenuation. That means that plaque in that portion of the artery is full of inflammatory cells. So that plaque is a hot plaque. That's a vulnerable plaque. That plaque is likely to rupture in the future. And if you have out of all your plaques, if more than 4% of your plaque, 4% is low attenuation, now I turn around to that patient and say, you have a lot of soft plaque. Okay, fine. But I have identified features of that plaque and you are vulnerable. That plaque can suddenly crack, and the day that it cracks, there's going to be an unpredictable blood clot that will form. It could be a minor one, it could be a major one. I just don't want it to rupture in the first place. So I'm going to do everything possible to look for inflammation in that patient to make sure that that plaque doesn't rupture. And if it does rupture, I'm going to do everything possible in the blood to make sure that the blood clot is not very big. So that's how we approach it. So if you want to identify plaque today, there are methodologies to do it. A coronary calcium score is just a coronary calcium score. It is very helpful because if you have a coronary calcium score of 0, doesn't mean you don't have soft plaque. You could have some soft plaque. But because none of that got calcified, because none of that soft plaque gave rise to coronary calcification, you have a physiology where you have soft plaque, but your body is able to cycle through it and not have so much inflammation that it gets calcified. So it identifies soft plaque perhaps with characteristics that are unlikely to rupture. Why? Because if your coronary calcium score is 0, the chances of you having a heart attack or a major coronary event in the next 10 years is extremely low. It's so low, it's like less than 0.1%. Not 0, but very, very low. And the higher the coronary calcium, there's a higher the risk that something's going to happen. One day, you're going to get a heart attack or unstable angina, or you could even die suddenly, which I'll explain how all these plaques can make you die suddenly. Besides the clotting, there's other factors too. But basically, if you have a lot of coronary calcium, you have plaque. And that plaque, because you have so much calcium, it means your physiology is such that there's been a lot of inflammation. And the end result of that inflammation is calcification of that artery. So your physiology is not good. You're making too much calcified plaque. That means your soft plaques are rapidly going into hard plaque. So you better do something about this. You're not like the guy with a 0 score where his soft plaques may not become calcified because he's otherwise okay. So doing a coronary calcium score is a great start. I'll do that on that patient and see that, okay, now your coronary calcium score is less than 100 is mild, 100 to 400 is moderate. And anything more than 400, you've got my attention, big time attention. Because that calcium that's built up on the calcium score doesn't tell me whether it is narrowing inside the artery or just sitting on the outside. Okay? If it's sitting on the outside of the artery and not narrowing on the inside of the artery, there's not going to be any flow disturbance. So what happens? I need to know whether that 400 or 300 or 200 plaque or more is narrowing inside the artery. Is your plaque occlusive or not? What's the next step? Well, it gets a little technical here. You can do a stress test, because a stress test will tell me whether you have narrowing that is causing a flow disturbance. So let me explain. In a stress test, it'll pick up a blockage that's more than 70%, because that's where it starts reducing the blood flow. So you fail your stress test. Yes, that blockage showed up on your stress test. It's a flow limiting lesion. If it is a flow limiting lesion, you've got to do something about that. Why? Because you can't be running on your treadmill and not getting enough blood supply, because you can get an arrhythmia. You can also, if you don't get an arrhythmia and die, you're going to get left ventricular dysfunction, which means that your heart muscle is not going to work very well because it's just constantly not getting enough blood supply, and you could run into congestive heart failure. So you want to get rid of that blockage. And how? A mechanical problem requires a mechanical solution. So if you have a tight blockage, you either put a stent in it or you bypass it, because it's flow limiting. It's a mechanical problem. I can't tell you that you got a mechanical blockage and say, yeah, all my supplements, here's my lifestyle, I want you to do X, Y, Z. That's not going to solve the problem. That's why I get so excited as a cardiologist, because if I was only looking at the prevention aspects of it, then I'm missing a whole part of it. That, wait a second, this patient's got a flow limiting lesion. So I'm so blessed that I'm actually able to go in, fix that blockage, and then say, okay, now let's see what we can do about your non-occlusive plaques, what we refer to as non-occlusive plaques, right? So the CT scan that we do on people, the CT angiogram, I told you it can look at plaque analysis. That is an AI-driven program. And it'll tell you how much soft plaque you got, the volume in each of your 3 arteries, and it'll tell you about the characteristics of your plaque, whether it is calcified, and the soft plaque, whether it is very low attenuation or not. The angiogram portion of it, where the dye goes into the artery, can tell you how narrow it is. Now comes another technology that is so exciting, that really changed things in the last couple of years, and that is called FFR. So FFR, it's called fractional flow reserve. So it's very important that people who are interested in coronary artery disease must understand what FFR is. If you don't understand FFR and you've got coronary artery disease, you have a problem. You better understand it today. So fractional flow reserve, what does that really mean? It started in the cath lab, where there's a narrowing. And you look at the angiogram and you say, oh yes, I can see a blockage. It's not 90. It's not 80, it's around 60, 70, maybe 80. I'm not sure whether this is actually limiting flow or not. And I don't have time to do a stress test. So what am I going to do? So we took this pressure wire and you pass the lesion, measure the pressure beyond, and then you do a pullback. Very, very simple, right? Sounds very simple. If there's a step down, that means you know that there's low pressure on this side, there's high pressure on this side. You work it out, and that's called the FFR, fractional flow reserve. And if it's less than 0.8, that means there's a significant drop in the pressure on the other side. So this is a hemodynamically significant lesion. Studies have been done that if you then open that blockage up, you get much better results, because you are stenting hemodynamically significant lesions. So the FFR started in the cath lab to determine which blockages are actually causing flow limitation, which ones are not, rather than just doing an angiogram and looking at it and guessing that, oh yeah, you got a blockage there, it's 80%, and I'm just going to stent every blockage that you got. Because we did that. We did do that. And we found that the more metal we put in the patients, the more stents we put in them, the worse the outcome was. It wasn't very good. You only want to stent the lesions that are Hemodynamic is significant. And FFR has allowed us to do that. A positive nuclear stress test allows us to do that. So this same technology of FFR now with AI has come into CT angios. So with the CT angiogram, once you get the images, you send it off to a company that calculates the FFR. Right now, it's a company called HeartFlow. And I send off the discs to them, and they look at that, and the AI calculates the FFR, and the correlation is with invasive cardiac catheterizations, and it's extremely good. So, of course, the quality of the study has to be good too. So there are, I would say, at least about 20% of the times, it's the quality of the CT angiogram may preclude a FFR determination. So then I have to find another way to determine whether there's flow limiting lesions or not. But AI calculates the FFR, and then the report comes back to me say, yes, there's a blockage. It looks like it's about 70, but the FFR is abnormal. Or it looks like it's 70, but the FFR is negative. So that's another piece of information that tells me about flow limitation due to the plaque. Because we're talking about the plaque. This plaque stuff is terrible. It ruptures, it obstructs, it's unpredictable. So this is another technology, FFR. So you have your stress test, invasive FFR, and a CT FFR that can tell me all this right here in the office, right here. Technology has just come so far. Of course, a lot of the insurance companies are still a couple of decades behind the times. So it makes it difficult for the patients, but those who really want to know can get this done. It does sometimes mean they have to go outside their insurance because not all the insurances want to pay for plaque analysis, nor do they want to pay for the FFR. But relatively, it's pretty inexpensive. So we do have that technology of FFR. So let's say that fellow comes to me and he says, I turned 40, I have a little baby at home, and tell me, I'll do the coronary calcium score. If it is abnormal, if it's high, I'm going to do a CT angiogram. That's going to tell me plaque analysis, FFR, narrowing of the arteries, and I can be able to sit down with the patient and say, this is what you got in terms of your plaque. Now, that's just part one of your workup. Don't think it's over. Just because you did a anatomical study looking at your coronary arteries and looking at your plaque, there's a whole biochemistry which I'm going to dig into in just a second, because this just tells me the consequences of your plaque. Now I'm going to do a deep dive into why you got the plaques in the first place. Why?
Before we get into that, let me jump in for a sec.
Sure.
I want to make sure I understand this piece here about stenting. When flow is affected to a certain point, a stent is warranted. I think you mentioned the fact that if we change the lifestyle, we can't reverse the plaque. So let's talk about that. Somebody that wants to go at this purely from lifestyle, diet and lifestyle, can they reverse plaque at all?
What a great question. I knew you were going to ask this question. So can you reverse the plaque? Okay, doc, I saw these blockages. My FFR is a little abnormal. I'm asymptomatic. Give me something that I can just reverse the plaque because I don't want any stents inside me. And the answer is yes, you can. Now, how much can you regress it? I told you that it's a dynamic state of affairs, right? There's soft plaque and there's hard plaque. Soft plaque can regress. Hard plaques are harder to regress because they are hard. However, within the hard plaque, there's always some soft plaque also. So the answer is yes. With aggressive lifestyle changes, dietary changes, environmental changes, changes in your toxicity, changes in your food, everything else, you can. But the extent is probably, the percentage stenosis is probably very low. That means you can reduce it by maybe 10%. And I've seen that. I've done an angiogram. The plaque is looking like it's 80%. The patient did not want a stent placement because he's relatively asymptomatic and he's very, very motivated to make lifestyle changes. He does it. And for whatever reason, we cath him again 6 months or a year later. And I found that the blockage actually looks a little bit better now. Now, that the regression of that plaque is possible, but don't think that we have a Drano that can just clear away the plaque. This is dangerous thinking. You will regress it somewhat. But I want you to also understand something. The flow in the cylinder is related to the fourth power of its radius. That's Porcel's law. We were taught in school, but we all forgot about it because of the way they teach it to us. We just forget the relevance of it. So when you improve the lumen by 10%, by regressing it a little bit, you're actually improving the flow tremendously. So there is some benefit even in moderate reduction in the percentage stenosis. And the answer is yes, you can regress it, but you cannot get rid of it completely. When you go back and again inside, there will be a narrowing over there. It may be a little bit less, but you need very aggressive lifestyle. You need to know the factors that made that plaque in order to reverse it. You can't just say you got a plaque now, just do A, B, and C. And we're going to come to that because I know you're going to come to that. But you got to know what was driving it. And then if you hone in on those aspects, you can hope that there's going to be some regression. But I've never seen a case where the patient has multiple blockages and serious blockages, come back to an angiogram and they're all gone. I've never seen coronary calcium 400 go to 0. I've seen 400 go to 300. I've seen 1,000 go to 800. I haven't seen 1,000 go to 0. So I just want everybody to know that, because once the calcium sets in, there is some turnover, but the turnover is limited. You will get some reduction, but you will not get elimination. Now, it's nice that the numbers go down because that means that the burner's off, that you're not cooking anymore inside. That's good news. Stop cooking your arteries. That is good news that it hasn't increased, but it's not going to go away to 0. When a plaque regresses, it also means that it's metabolically more stable now, that it's not so hot. Like I said, the low attenuation defects that you see on the CT angio, you're not going to see that because it's regressing. So the answer is yes, you can regress it. And now there's another part 2 to this.
Let me jump in one more time before we get to the next part, because I want to make sure I understand this section before we move on. If you put a stent in, we know the danger here is if the plaque ruptures, forms a clot. If we put a stent in, is there still fear of a rupture, or does that pretty much nullify it?
Basically, that plaque that you just stented, you put a bomb in there, basically. Basically, you just squashed the heck out of it into the walls. So that piece of artery where the stent is needs to repair itself. Now, this is very important. When the artery repairs from the damage that you just did with the stent, it's a process called intimal hyperplasia. It's not atherosclerosis. So what happens is that the smooth cells, which are in the wall of the muscle, they migrate into the intima and they cover over the stent. That material is called intimal hyperplasia. It transforms cells from the smooth muscles as they become intimal cells. And when you go inside and look at it with an angioscope, its characteristics are totally different. So that piece of the artery will now look white, and it'll be shiny, and it'll be very smooth. And that's called intimal hyperplasia, that's covering over that stent. So that portion is extremely unlikely to crack, because cracking occurs in atherosclerotic plaques. But there are other parts beyond the stent, before the stent, that could rupture. You see? So when you do this, when you put a stent in, the natural history of that particular portion of the stent, the artery where you put the stent, is now going to be dictated by the damage that you did. Now, let me explain. When we put stents in these days, we use drug-eluting stents. What's all that all about? Why don't we just put a regular stent in? And I'm going to explain to you why. Because when you put a regular stent in, you've damaged the wall, you've spread it out, it's going to repair itself. And the repair process, which is too much, like a keloid that grows, causes re-narrowing of that artery in that segment. And if that stent re-narrows, we call it restenosis. That restenosis is because of intimal hyperplasia. It's not due to atherosclerosis. So you could have the best lifestyle that you possibly could have. And if you've done enough damage in that area, and if your body's physiology is that it overcompensates and it covers over that stent too much, the material grows into it too much, you're going to end up with a narrowing. And it did happen in 20% of patients where you put a stent in, and then they come back 6 months later and they got a stent restenosis. Then you got to go back and do something else to it. So then what we did is we came up with drug-coated stents. So the drug-coated stents are covered on the stent. We put a chemical on it which prevents mitosis. Mitosis is cell division. I told you that the intimal cells migrate from the smooth cells. They move into the intima, they transform, and they become intimal cells. So it's cell division. They need to divide and grow. And that's what overgrows on the inside of the artery. So this drug prevents mitosis. So now there's going to be a decreased amount of intimal hyperplasia. But that's why you need to be on an antiplatelet agent for 1 year, because it takes longer now because of the inhibitory effect of that drug to cover the inner lining of the stent, because the stent has to get covered over, usually just by a couple of cells layer of intima, that then the blood is no longer exposed to the metal. That's why you have to take the antiplatelet agents, and it can take 6 months to a year before that stent gets fully covered over. That is why after doing a stent, you have to be on antiplatelet agents. And this is a very important point you brought up, because if you don't take the antiplatelet agents, you can have a couple of struts that are still not covered over, and therefore they form blood clots on it. And I told you that part 2 of this is blood clots, and the blood clots can occur on a stent as well, just as it can on a piece of plaque that's ruptured. So you have to be on antiplatelet agents. So the intimal hyperplasia now with drug-coated stents is reduced. So when you put a drug-coated stent, the restenosis rate within that stent is less than 5%, which is wonderful news, because that means that segment has a less than 5% chance that it's going to have a problem. And if a year goes by and if it hasn't narrowed, it's unlikely to give a problem. Long term, there's a 0.001% chance that stent will be a problem. But the problem is not that. The problem is it's going to get progressive disease because we're not doing enough prevention. So another plaque is going to grow. So general rule, if I do a stent on you and you come back within a year with symptoms, it's likely I have to look at that stent. If it's more than a year, you've got a new blockage somewhere else. You have now developed new disease, de novo disease, somewhere else. Why? Because of failure of your prevention plan. Yeah. So you are still at risk of rupture, not at the site of the stent, but in another site. That's the message. That the answer to your question is yes, you still are, but in a different segment. You see how interesting this is? It's fascinating, because people think that they got a stent and I'm done. No, you're not done. No, you're not done. You got a stent. Okay, fine. That segment is now under control. What about the rest of you? That's where you're going to rupture a stent. There is a thing called edge restenosis, which is right at the edge of the stents. Because you see, there's a cardinal rule when you're stenting that you want the edges of the stent to be in normal segments where there's not much plaque. But if the edges are still within a plaquey area, then you can get edge restenosis as well. So part of that's technical. So a good interventionist will cover the narrowing and just beyond it. So you land the ends of the stents in normal segments so that you don't get edge restenosis, because that can happen, or even rupture, as you said. But again, that's normal segments. Yeah. It's your other artery that's going to be a problem. It's the rest of the artery that's a problem. So, when a patient has a stent, they often come back to me and say, oh, yeah, but then, I know a friend who came back, and then a year later he got a second stent, and then a year later he got a third stent. And if you go back and look at the history, it's usually a new blockage. It's not a failure of the stent. It's a failure of your prevention program.
Well, this ties into what you started with, saying the fact that this is a systemic problem and inflammation's at the root of it. So a stent is a Band-Aid and there's a use for it, but we got to get to the root of why all that happened.
I love it what you said. It's a Band-Aid. A stent is a Band-Aid. Now, is it useful? Of course it is useful, because it's going to take away your symptoms, first of all. First thing you're going to get for the stent is you're going to get a relief of the pain, or you're getting relief of the ischemia. The ischemia may be silent, because remember I told you 8 out of 10 patients don't actually get the chest pain. You're relieving ischemia, and ischemia is a good thing to get rid of. But it's still a Band-Aid, because you just found something, you fixed it, but wait, the fire is still on. So I was coming to the fact that I wanted to tell you about collaterals. So let's say that patient came to you and said that, hey, doc, yes, I don't want to put a stent in me. I have an 80% blockage. I failed my stress test, not in a big way, in a little way. I want medical management. Perfectly okay. Now, a couple of things I want you to understand. When you flunk a stress test, it's not just plus or minus, which many people think it is. It's not. So let's say only a small portion of your heart was not getting enough blood supply. Yes, you failed your stress test, but is that catastrophic? Can I do medical management on you? Can I say to you, you know what, you have a blockage, but you want medical management only and you want to do lifestyle changes and prevention? I'll let you do it. But let's say you do a stress test and the entire front of your heart gets wiped out on that stress test. And then you come and tell me that you want to do medical management. I'm going to say no, because that thing is causing so much ischemia in you. You may not be feeling it, but it's going to kill you. For example, a widowmaker, right? A widowmaker is at the beginning of the artery. And if that's causing a problem, it's causing so much ischemia, so much lack of circulation. There's no medical management for that. So yes, the answer is that some patients want medical management. You can do it. You got to look at the ischemic burden, as I call it. What is the ischemic burden? It's mild. How much muscle is in jeopardy? A small amount. So let's say that he shuts it off in that area. He's going to get a tiny heart attack. He'll survive it and he'll move on. So there are cases where we do medical management. But when we do that, we do a lot of prevention and we want to build collaterals. So that's an important thing. So let's say that you do have an 80% blockage and you want to do medical management. You need to build up collaterals. So you work very hard on your prevention program, exercise program, which we can talk about later on, and EECP and treatments like that increase your collateral blood flow. Because at the end of the day, when a plaque ruptures and shuts down the artery, how much damage you're going to get at the bottom depends on your collateral blood flow. If you have collaterals, the damage will be limited. If you don't have any collateral, so you know, people say that, oh yeah, this 56-year-old guy who shut off his LAD, he gets a massive heart attack. The same artery in an 80-year-old doesn't cause much. I mean, yes, he's still getting a heart attack, but he's likely to survive it because the 80-year-old has more collaterals over time than the 56-year-old. That's why a heart attack in a young patient is catastrophic. Most of the time, they don't even make it to the hospital. Why don't they make it to the hospital? Why do heart attacks don't make it to the hospital? 50% of heart attacks never make it to the hospital. The artery shuts down, they start getting chest pain, and the EKG source changes. They die in the ambulance or they die at home. Of what? They're not dying of the heart just getting so much damage. They die of an arrhythmia. That is why as soon as you're getting a heart attack, you need to be monitored. Get that ambulance in, because if your heart stops beating, you need a shock. So 50% of the patients, they die of an arrhythmia. So now you're seeing that I've introduced a whole new, it's not just the pump. It's not just the blood supply to your muscle that gives you the pump, right? If muscle dies, your pump is going to get weak and then you're going to get congestive heart failure. But when you get sudden abrupt cessation of blood flow, you are going to get an arrhythmia. And that's something that people just don't understand, arrhythmia. And I do want to say something about an arrhythmia here, because when patients have multiple blockages in all the arteries, a lot of plaques, and they died at home suddenly, then autopsies were done on those patients. And we go inside and we take a look. We found that at least 60% of the times, there was no ruptured plaque. And we see that, oh my gosh, all the arteries are open, but they're all severely diseased. So what did he die of? He died of an arrhythmia. When sufficient mass of muscle becomes ischemic, you get an arrhythmia. And you die before there's a chance for necrosis. This is important. Necrosis means death of the muscle. Artery shuts down. You've got 4 hours to get that blood flow going again. Otherwise, a substantial amount of that muscle is going to be dead. In the meantime, you're at risk of arrhythmia. But the more the muscle, greater risk of arrhythmia. That's why if you have a widowmaker, that's it. You just have to get revascularization. Why? Because you are at risk of an arrhythmia. You could be walking across the house and you'll just keel over and die of an arrhythmia. So arrhythmias are very, very important. Blood supply to the heart muscle is important. The electrical system is in the heart muscle. So don't think that they're not going to get spared. They are going to go into an arrhythmia. So that is why we are very, 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 if you have a large amount. So you see, the point here is that you need to individualize your care. Yeah, you flunked your stress test. How? How much muscle was in jeopardy? You flunked it. In the old days, you would just do a regular stress test. You run on the treadmill, you look at the EKG. And the EKG is either going to be positive or negative. But it doesn't tell you how much muscle is ischemic. Now, we have two additional types of stress tests that we do. One is a regular nuclear stress test, and one's a PET stress test. These are nuclear stress tests. So what you do is, in addition to looking at the EKG portion, you're looking at the distribution of the blood flow. So my heart is like a balloon. My front is not getting enough blood supply, or my bottom or the back part of the heart. And you can actually quantitate, you can actually see, even visually, how much of the heart muscle is being deprived of blood flow when you're exercising. So if it's a small amount, okay, it's a branch vessel disease. So when you angiogram that patient, you'll find that the distal branch is blocked or narrowed. But if it's the beginning of the artery, or the widowmaker, which is the left main, then you'll see that the entire front is abnormal. So it's not just black and white. You got to thoughtfully look at the stress test as well. And then you do what is a risk assessment for that patient. Is this patient a high risk or low risk? And you got to give that. So that is important. And then, of course, the whole prevention program is important. But just the cardiology part of it has really evolved, and we do have this technology. We do have it. It's just sometimes not adequately used, or there's not enough thinking that goes into the stress test interpretation. It's not black and white. So I wanted to stress that, because that's really important. Because you're right. If somebody comes to me, he's asymptomatic, he's got a coronary calcium score that's moderate, his stress test is positive, but a very small amount of it is abnormal. And let's say he wants to go for a hip replacement. What am I going to do? No, you cannot go for hip replacement. You need perfect perfusion in your heart muscle. No, I'm going to clear him for a hip replacement. I'll send him there, but I'm going to do a lifestyle change. And I see that a small portion of his heart is not getting enough blood supply. He can still actually go for surgery, and he can still live a pretty good life. We got to do the prevention program, because the risk of arrhythmia is low. Even if that artery shuts down, he's not going to go into cardiogenic shock. Cardiogenic shock, meaning a whole bunch of muscle just died, and his heart is now doing this instead of doing this. See? So, so where is the plaque? Which portion of the artery is the plaque? Is the plaque in the beginning of the artery, the middle, or the end of the artery? Is it in a branch that's causing a problem, or is it in the left main? All these things are important considerations when you're interpreting a stress test or an angiogram for that matter. So, and the decision about stenting versus bypass surgery is a very important one as well. Do I send patients for bypass? Of course I do. A lot? No, hardly. But I do. When I do because they've either got left main or they've got a blockage that is serious and I can't fix it because it's at a branch. So if I fix one branch, the other one will shut down. This is a critical decision. So those types of patients where they have multiple branch disease, which I cannot stent, and he has a lot of ischemia, his ischemic burden is high, those patients need surgical revascularization, where you're bypassing the plaque, you're bypassing the blockage. So these are the kind of critical decisions that we've learned to make over the years, because we used to send a lot more patients for bypass surgery, and we send much less patients for bypass surgery nowadays.
Our thesis is that when it comes to plaque or blood clots, inflammation's at the root of it, and this is a systemic thing going on.
Yeah.
Let's start talking about what we do for prevention. Somebody's on the continuum, whether or not they're young and healthy, no plaque, or they're more advanced and they do have plaque, but they're ready to take this seriously and make the changes. How do you begin with the patient?
We always do a history and physical first. The history is important. So what other conditions does he have? that could be contributing to his hardening of the arteries. So we know, for example, smoking. I don't need to beat that horse down. We already know about that. You got to quit smoking because smoking contains 7,000 different chemicals in it. We don't know which ones even destroy the arteries, but to me, they all destroy the arteries. So smoking. Diabetes. But it's not just diabetes, it's pre-diabetes. And I think I've beat that horse down a lot too, because look, by the time you have diabetes, you have systemic atherosclerosis. Take that. You have to memorize that. By the time you're diabetic, you already have widespread atherosclerosis. So we look for that, okay? But I'm also looking for pre-diabetes. And how did this happen? I'm going to explain to you how this all happened. It all happened right here in my clinic. These patients were coming back with more disease. And like you just said, what am I going to do for prevention? So I did the blood work and none of them were diabetics, but the sugars were running around 100. So I did a glucose tolerance test on them and they were abnormal. And they had not diabetic levels of blood sugars, but what we call glucose intolerance. So the fasting glucose was high or the glucose went up to 200 and took longer than 2 hours to come down. So I identified these patients. Then what I did is I took a bunch of my patients in whom I did stents, and I looked at 100 of these patients, and I found that 70% of them who were not diabetic had insulin resistance, meaning they had high blood sugar problems. They were not diabetic, but they were pre-diabetic. We didn't know about insulin in those days, because I'm very old. I'm talking about 20 years ago. After that, I started measuring insulin levels because I got a little wiser and I started doing what is known as a Kraft test here in my office where we were measuring insulin levels. And I found that these 70% of the patients who had prediabetes, what they call prediabetes, had extremely high insulin levels. So in spite of the sugars being decent, they had so much insulin, and that seemed to identify a whole group of patients who were extremely high risk of having a new event, another stent, progressive disease, increasing coronary calcium, heart attack rates. So your metabolic condition, the biggest metabolic condition I found was prediabetes. So let's say a patient comes and says, I want to know what's going on. I'm going to be looking at that. I order a hemoglobin A1C. That's a test for diabetes. Comes back normal. Normal meaning less than 5.7. Doesn't mean anything to me. If you got coronary disease, even though your hemoglobin A1C is less than 5.7, if you have coronary artery disease, you need to do the insulin test. That's a blanket statement I've made, but I stick by that because you'll be surprised how many patients have normal hemoglobin A1Cs, but the insulin levels are still high because they got coronary artery disease. If you got coronary artery disease, you have to rule out hyperinsulinemia. If it's between 5.7 and 6.4, they'll say you got prediabetes. So what? Measure the insulin level, and it'll be exceedingly high. The way you do that, you drink sugar water, measure the glucose and the insulin level half an hour, 1 hour, and 2 hours later. It's a standard test that we do. Once I identify hyperinsulinemia, give me a drug that's going to bring insulin levels down. There is no drug. There's no drug to bring insulin levels down. I can bring your hemoglobin A1C down. I can give you diabetes medication that'll bring your sugar level down. But none of those medicines will also bring your insulin levels down because you have insulin resistance. This is a problem that I run into, not only with patients, but with my own colleagues and other subspecialists in other fields of medicine. The hyperinsulinemia is deadly. And whenever I bring insulin levels down, the patient's outcomes are better. How do I bring it down? Well, I'm just going to tell you the brief treatment, and we can come back to this. It's basically fasting. And I've done lots of videos on this, and I've seen drastic changes in the patients because the insulin levels come way down. The patients feel and look great. And guess what? They stop coming. Well, they come for regular checkups, but it's now once a year and it's goodbye. So insulin. So I'm always going to look at your metabolic condition. I'm going to look at your hemoglobin A1C, your insulin levels. I'm going to look for a fatty liver. I wonder, what's a cardiologist looking at a fatty liver for? Metabolic disease. If you have high insulin levels, you're going to have a fatty liver. There's only 3 reasons why you can get a fatty liver these days. And by the way, almost 3/4 of us have a fatty liver, which is really not a good thing. It's either because you're an alcoholic or you're drinking too much or you have other toxins in your body, or you have hyperinsulinemia, or what I call these days is leaky gut, but call it intestinal permeability, which we'll talk about, because all that inflammation from the gut has to first be processed in the liver. So this is going to lead to a big conversation, and I can already see that your mind's spinning with this, because if you got a fatty liver, you better know why you got it. And you have to turn over every stone and look to see why this patient's got a fatty liver, because fatty liver is linked to coronary artery disease, hypertension, stroke, dementia, premature aging, even cancers. And yet, it is probably one of the most overlooked things. So I always order a liver ultrasound to look for it. There's another way to do it also, which is you can order a CT scan and it looks at visceral fat. Very important. And you need to have a distinction in your mind between visceral fat and how malignant that is compared to subcutaneous fat. Because I see patients in my office all the time. They're obese. They got fat all over. But metabolically, they're perfectly healthy. They don't have visceral fat. They don't have a fatty liver. They're just fat. That's it. So those are metabolically healthy patients. And they don't have coronary artery disease. And even if they do, the coronary calcium score is very low, because sometimes as we age, we can also build up some coronary calcium too. But they're not pervasively sick the way the metabolic patients are, where they have a fatty liver and they'll always have a protuberant abdomen. Protuberant abdomen where you can't pinch the fat. Protuberant abdomen that's taut. So I can walk into the room and tell which patient's got a fatty liver and which one's got a visceral fat, and which patient therefore is metabolically abnormal, is going to have a high insulin level. So we do the liver ultrasound. Then the next thing we do is that I do a series of blood tests. And the blood tests are looking for inflammation markers in the patient. So we'll talk about the blood test, but still, while they're in the room, the history, right? So we talked about smoking. Then I always look at their diet. What are you eating these days? How often do you eat? How many hours of sleep do you have every night? How do you feel first thing in the morning when you wake up? Do you have skin problems? Do you have a rash? Do you have joint problems? Then the big question also is, do you have gut problems? So cardiologist asking about the gut. We'll come to that. If you're having gas, distension, diarrhea, constipation, gut never feels right, you have a problem. So all this is part of the history taking. The history on a cardiac patient involves the circulatory system, respiratory system, asthma. You have asthma, you grew up with asthma, you have a problem. And now you're going to have inflammation that's related to your heart as well. So you've got to take a complete history, GI history, skin history, brain. You have mental fog. Yeah, wake up really fatigued and tired. You don't snore at night. Then why are you waking up tired, fatigued, tired? And then a complete history of what's happened to you before. So I want to know from the time you were born. Why? Because I want to know whether your physiology changed. Did your physiology change as you were growing up? Because when you were born, you didn't have coronary artery disease. So what happened? What happened to you? Well, I want to know everything. I want to know about every trauma you had. I want to know about every episode of antibiotics that you took, how many courses of antibiotics you took, what other diagnoses were made with regard to your gut, your microbiome, food sensitivities. I want to know about your exposure to toxins, including mold and environmental toxins, tobacco, of course, secondhand smoke, where you work, what kind of environment you work in. All this is part of the history. We haven't even started yet. We're just in the room talking. And you get that whole, so you get a background picture of what's going on with this patient to determine whether he's going to be a victim of inflammation. What is inflammation? Inflammation is you reacting to something. I want to know what that something is that's driving your inflammation. Because these patients are not smoking. For example, the patient that I just saw a week ago, completely healthy guy walks into my office, shows me a calcium score of 2,000. I'm like, how come you got all this? Why? How did you get a 2,000 score? So a deep dive into the history. And you know what? Most of the time we'll know why he got that coronary calcium score and what made it happen. I told you it's the graveyard of inflammation. So he's got it. My job now is to make sure he doesn't have ongoing inflammation. So the history is really, really important because it does direct us in certain directions as to what's going on with this patient, what's causing including his lifestyle. Because you can be inflamed because of your lifestyle. See, generally speaking, you inflame because you are nutritionally insufficient. So you can't handle even the normal stresses and you get inflamed, stress factors. So you may be, for example, if you're severely vitamin D deficient, that's a typical example. And I see a lot of vitamin D deficiencies as well. If you're severely vitamin D deficient, your stem cells are not going to be able to be released from your bone marrow that will go out and repair the endothelium of your arteries. Your progenitor cells, which are the stem cells, that go in there and repair, because you and I, right now, our intima is being damaged because we're alive. But our body repairs it. And the repair process is the stem cell stuff that goes around and they replace the cells in your intima of your arteries. And if you're deficient in your nutrition, especially things like vitamin D, you're not going to be doing that. So it's very important that I look at everything. So it's nutrition deficiencies. Next, I'm going to look to see whether you're metabolically right or wrong. So I already told you about the insulin, and there's a bunch of other tests. And then the next thing is, are you toxic? So if you're toxic, this talking about toxicity from a cardiologist sounds like he's gone off the deep end, but he's not. We are toxic. And I've seen it, and I've evolved to include toxicity workup as part of my plans. And I have worked out the biochemical pathways by which toxicity creates atherosclerosis in the body and inflammation. So if you are heavy metals toxic, if you have a lot of mycotoxins in your body, mold, if you have a lot of glyphosate and you have a lot of other herbicides and pesticides and plastics and BPA and phthalates in your body, they don't belong in your body. You didn't evolve with them. Evolution, you did not evolve with them. So your body's chemistry, you see, this is common sense, but yet we don't want to accept it because we're so used to this Western lifestyle. The fact is that those chemicals are not supposed to be in your body. You do not have the mechanisms to cope with it. A small amount of toxins, you can cope with it because your microbiome will take it and will get rid of it. So okay, I had salmon the other day. You don't think I got some mercury in me? Of course I did. But I have a great microbiome. And that'll limit the amount of mercury that came into my body. And I have a fantastic liver. Well, how many people can tell me that they've got a fantastic microbiome? And how many people can tell me they've got a fantastic liver? So you see our problem, it's a pervasive problem. We don't have the means nowadays to get rid of toxins, and the toxins are pervasive. They're everywhere. And the body reacts to them. Why do we think that the body does not react to it? When we know that these heavy metals, for example, will disrupt your glycocalyx because they're a heavily charged atom that sits against the negatively charged glycocalyx. And therefore, there's going to be an interaction, and that denudes the endothelium. Now your glycocalyx there is lost. And now that endothelial cell is going to get activated, so it'll start producing adhesion molecules, for example, that will adhere to passing by monocytes. And those monocytes will transform into macrophages. And these macrophages will grab hold of small, dense LDL, which is the bad LDL, as we call it, the small, dense LDL, not regular LDL. If my macrophages were eating LDLs, I'll be dead. It's the small, dense LDL. So what I'm trying to say is that we've worked out the mechanisms of toxicity from any of these things. So I have evolved now to include toxicity testing as part of my workup in these patients. So I will ask them. For example, I saw a patient just 2 weeks ago. He was a firefighter. Very healthy, worked out every day. He was not Hulk Hogan, but he was close to him. It was fantastic. He looked so good. coronary calcium score was almost 4,000. And it's because he has been exposed to a lot of toxins. And when I did his toxin workup, sure enough, he had a whole bunch of toxins in him because of the exposure, plus the fire repellents that they carry with them all the time, and all those plastics get in as well. So there are multiple reasons. And of course, he had circadian pattern disorder, sleep. See, a fireman doesn't get the sleep that you and I do. We totally ignore sleep. You don't think that sleep is a pro-inflammatory problem if you don't get enough of sleep or deep sleep? So, sleep. How many hours do you sleep? How do you feel in the mornings? Do you snore a lot? How often do you travel? I see these pilots here all the time, and they got coronary artery disease. And one of the reasons is because their whole sleep patterns all out of control. So that causes hormonal perturbations as well. And you don't think that that's going to affect the atherosclerosis and inflammation in your body? Of course it's going to do that, because all the hormones in your body, when they are not in control, are going to cause inflammation as well. So it gets really complicated when you do a deep dive. That is why when we do the prevention program, it takes hours. The first interview is almost 2 hours long. And then we do subsequent follow-ups after we do some blood tests and everything else. So the history is very important. Then the physical examination is important, and then the blood work. So I do the blood work. We do what I call the Cleveland Heart Labs, which is a batch of blood tests that I have come up with, which includes all the inflammatory markers in it, insulin levels, and it has some of the B12 and D3 levels and coenzyme Q10 levels as well. So it has all, and it looks at a small, dense LDL. Now, this is key. And I got to tell you about this because there's a lot of misunderstanding about LDL. Most people, all they know is LDL is a bad LDL, bad cholesterol. And that's not true, because if your macrophages were engulfing and eating up LDL, I'll be dead. LDL is part of your mechanism. Cholesterol is the mother molecule from which a lot of hormones in your body are made, and without that, you cannot survive. It is the damaged LDL. That's the problem. The macrophages don't devour normal LDL. They devour and eat up small dense LDL, which is abnormal LDL. And then that's described as a foam cell. And you know that a foam cell is part of atherosclerosis. It's part of the plaque. The foam cells, when you open them up and look inside them, it's small dense LDL. So why do I look at small dense LDL? Because that's the cover. If you have small dense LDL, then the next question is, why is my LDL small? What damaged it? That's $1 million question. So I know that basically 6-7 causes of small dense LDL, and I'm going to be chasing them. The first one I already mentioned to you is to do with insulin and glucose. If you have an hyperinsulinemia, you almost certainly going to have a high triglyceride, low HDL, small dense LDL particles. So you're going to be chasing that insulin and that sugar, and you got to get that down. The next thing that I know that causes small dense LDL is omega-6. You eat a lot of vegetable oils, almost guaranteed that those oils go to the normal LDL and displace cholesterol from it, take up its room over there. And now you've created a small dense LDL, cholesterol's gone, and replaced it with that omega-6 on it. Omega-6 is pro-inflammatory. That's why none of my patients will eat vegetable oils. The next thing is advanced glycation end products. Oh, what does that mean? These are when you cook your food at extremely high temperatures and you're creating these unnatural molecules. It's not natural to have proteins, fats, and carbohydrates all at such high temperatures and dry heat that you combine them all into a molecule and expect the body to metabolize it. You didn't evolve that way. Your body did not. The most your body was allowed to do is probably a fire or steam or cooking water 100 degrees. But to go like these air fryers, for example, I'm totally against air fryers because you're creating all these advanced glycation end products when they get into the body, there are receptors to get rid of them because evolutionarily we've been barbecuing food. So we do have those receptors. But when we overwhelm them, these particles cause small dense LDL. And that's going to then drive the macrophages crazy, and the atherosclerotic process is going to start as well. The next thing is regular toxins, all these toxins that I'm talking about. But there's one in particular that I really don't like, and that's called LPS, lipopolysaccharides. Lipopolysaccharides are bacterial wall products. They get into your bloodstream from your gut. These are not bacteria, but the dead bacterial wall products. When LPS gets into your bloodstream, it makes small dense LDL. LPS does damage in and of itself also to your glycocalyx and your air lining because it's charged, it gets oxidized. By the way, have you thought about this? That how come if the LDL, oxidized LDL, is damaging the body, and if it's how come only the arteries get damaged? How come the veins don't? It's because these bad molecules go from your liver to your lungs, and they get oxidized in your lung. That's why you don't get atherosclerosis in your vein. How come you don't get atherosclerosis in a vein? Because the oxygen tension is different. And then when all that gets oxidized and comes back to the heart, the first place they're going to come to the heart is the left atrium, right? The 4 pulmonic veins coming back into your left atrium. And if there's a lot of inflammatory substrate inside your blood, you're going to get atrial fib, because that's where atrial fib comes from. So this is a good point to tell you that today, the commonest cause of atrial fibrillation is not mitral stenosis, it's not hypertension. I'm finding that the commonest cause of atrial fibrillation is metabolic disease. And when I fix that, atrial fib goes away. Then from the heart, the first branch is the coronary artery. So they're going to see the brunt of this oxidized LDL and other inflammatory molecules. And that's why you get coronary artery. Now, some of it will also go into your carotid. So you might get some disease in your carotid. But as it then goes to the rest of the body, the atherosclerosis goes away. You don't get it everywhere else. Diabetics get it because the whole body's metabolism is off. So they get peripheral vascular disease also. But when it comes to this metabolic endotoxemia, as we call it, the leaky gut, as we call it, these patients have a lot of coronary calcium. The highest coronary calciums that I'm noticing these days is not people who are smoking. It is in people who have a bad gut. And that's a whole separate workup that you need to do on them. But you see, we ignored all that. We ignored the fact, the medical profession ignored the fact that there's even a thing called leaky gut. Because when you scope them, you're not going to see it. These are bacteria that are wrong, or the food is wrong, causing inflammation, or there's toxins. But your gut is not right. Basically, your gut has become porous. And we have a lot of data now to show that if you chase that and you fix that, all of a sudden, the LDL particles become large again. See, this is not just theory. I've been doing this for a few years now, looking at small dense LDL, not a few, many years. That after we fix the inflammation in the gut, lifestyle, and everything else, what happens to the small dense LDL? The particles become big again. So the LDL size, which is measured in angstroms, 210, 213 angstroms, they become 224 angstroms. And that's where you want them to be. So when you look at the lipid panel, and you've seen these panels come across your desk, I'm sure they're pattern A. Oh yeah, I got LDL pattern A, and this guy's got pattern B. A is okay, B is bad. It's true. What are we talking about? We're talking about particle sizes. That's what determines whether it's pattern A or B. And you can only obtain that on the advanced lipid panel. The trouble is that you go to your regular doctor, and I'm not saying that they're bad or they don't. No, it's just the norm. They'll do a total LDL, total HDL, cholesterol, and triglyceride. That's it. So you don't know the characteristics of your LDL particles. All you know is that my LDL is 130, and therefore I have to be on a statin. But the question is not that. If your LDL is 130, what kind of LDL is it? What's your LDL particle size? You need a deeper dive. So you need to ask for the advanced lipid panel. If you're not asking for the lipid panel, you really have to put the curtains on everything because you not really understand what's going on inside you. It's not the total LDL. The studies show that total LDL is a rather poor predictor of who's going to have a cardiovascular event. What we call the hazard ratio is about 1.28, 1.29. That means it's 29% predictive that in the next 8 to 10 years, there's going to be a cardiovascular event. What carries an even higher predictive value is the triglycerides. It's 1.8. When you have a high triglyceride, you're going to have small dense LDL particles. So your surrogate for a poor man's surrogate for a small dense LDL is the triglyceride level. So, I've always said that you can look at your triglyceride to HDL ratio. When your triglycerides are high, you're going to have small dense LDL particles. When your triglycerides are high, you have a metabolic reason as to why it's high. And it's usually insulin resistance because your fat cells are sending out a lot of free fatty acids, which are going to your liver. Your liver then processes it, puts out VLDL, which is very triglyceride rich. And these triglyceride rich molecules interact with the LDL. And your LDLs become small because they exchange that triglyceride. So you get small dense LDL. So triglycerides are a very good clue. So if your triglycerides are absolutely normal, and normal is not less than 150. Remember, we've fudged a lot of the numbers. It's not 150, it's less than 100 that's normal. It's just that the population today has so much triglycerides that they just put the level at that, just like your liver enzymes. When I was in training, your liver enzymes more than 25 were abnormal. Now it's almost 45 because everybody's got a fatty liver. So they just bumped it up. Now, how daft is that? So we need to become more stringent, not more lax, if we want the population to be healthier. So I look for triglyceride less than 100. If it is more than 100, you should ask for the advanced lipid panel so that you can look at your particle sizes. And then say, oh my goodness, I got small dense LDL particles. And then you look at the rest of the picture also, and then try to figure out why you got small dense LDL particles. And then your goal should be to develop large, fluffy, good LDL particles. And we know that those are very good. For example, I'll tell you myself, my LDL level is about 170 something. Large particles. Calcium score, 0. So my triglycerides, 80. HDL, 75. That's what you want. You want a good high HDL and a nice low triglyceride. And then the LDL is going to take care of itself. You're going to have large fluffy particles and you can test for it. And then someone like me, I'm going to test coronary calcium. My coronary calcium score being 0, I know I'm going to be okay. See, and metabolically, I'm fine. My hemoglobin A1C is 4.9. That's what you want. Now, even if my hemoglobin A1C was about 5.5, I'll start worrying a little bit, and I might do more fasting, and maybe I'll reduce my visceral fat if I had that. So the advanced lipid panel is an extremely valuable test to look to risk stratify the patient, especially if they already got coronary artery disease. Look, if you already have coronary disease, if you already have coronary calcium, if you've already had stents, you absolutely have to do the advanced lipid panel. Unfortunately, across the world, many countries don't have that. But here in the United States, there's no excuse. It's available. You got to tell your primary care provider or your cardiologist that you want to get that test done.
Let's come back to our list. Oh, that's where you were going, actually. You
keep going.
Used the example there. I think there was 6 or 7 different ones you were going to go through. LPS. We finished that one. Continue.
Yeah. So we know that the leaky gut causes small, dense LDL particles. Then toxins. Toxins cause low LDLs. The particles become very small. We know that. The pathways have been worked out. One of the toxins that I'm particularly worried about are mycotoxins. Mycotoxins, I have seen a number of patients who have chronic low-grade inflammation in the body, It's because they have mycotoxins in them. So has the science caught up with this, where I can definitely say to you that, hey, Jesse, these people, they got coronary artery disease and coronary calcification definitely because of the mycotoxins? I don't have that data yet. But I do know one thing, that the particle sizes got better when we get rid of the mycotoxins. So the mycotoxins are detected on a urine sample. That urine sample contains all the toxins. That urine sample contains the following. It contains glyphosate and other herbicides and pesticides, because if you have those in your body, they're not just taking a ride. Your body has never seen those before. It's an inflammatory reaction. It will react to those molecules. These molecules destroy your glycocalyx. They also affect your mitochondria. And by the way, everything at the end of the day, it's all about mitochondrial disease. That's the final step by which these things hurt you, is your mitochondrial function. So these plastics, and the plastics are from phthalates, which are on your day-to-day household personal care products. They're not benign. Look, sometimes I have this very difficult conversation with my patients, and I have to tell them that, look, stop using these body lotions. First of all, you don't have dry skin, so you don't need to be putting body lotion on you. You can't even pronounce the names of most of the chemicals that are in that lotion. So why are you putting it on your body? They all get absorbed. And the studies have been done that on average, when a lady wakes up in the morning, gets ready, goes to work, she's got at least 100 man-made chemicals on her. Now, this is not right. Because you think it's only on your face or on your makeup, it all gets absorbed. And these studies have been done. After the shower, immediately phthalate levels in the urine go up. That's been shown over and over again. You get out of the shower, you already have phthalates coming out in your urine. Phthalates, fortunately, that's the plasticizer that makes the lotion nice and greasy. Okay, that's fine. But they're not normal particles, and they've been linked to inflammation, not only in animals, but even in human studies. BPA, for example, which is a plastic, which is nowadays, they're saying that they got rid of it because they don't line the cans with it. But they replaced it with BPS, which is just as bad. Nothing from a can. Don't eat anything out of the can. I don't eat anything out of the can. No good. They'll always substitute one for the other. So all these plastics have been shown, and the biochemical pathways have been well established to show how they cause inflammation in the body. Then the mycotoxins. The mycotoxins come because you either exposed to it every day or you already have the mold in you. If you have the mold in you, you're constantly inoculating yourself with that mold. So I have found that many patients are mold toxic. And the symptoms that I get from them are, okay, I fixed your heart. You're looking good now. Why are you still dragging your feet? Why are you still fatigued and tired? How come you have mental fog? How come you're just good for nothing, and by 3 o'clock in the afternoon, you're just taking a nap, even though you don't have sleep apnea? Even though you slept 8 hours, you still have no energy whatsoever. How come you got all these rashes? How come you can't tolerate certain foods? How come your immune system is out of control? So you get every little cold that goes by, and you're getting it. And what's the skin rash all about? And how come your joints are hurting so much? So if you don't do a deep dive, you'll just chalk this down to, oh yeah, he's a little depressed. And look, that really bothers me, because nobody willingly wants to be depressed or wants to be anxious all the time. But these toxicities are causing that phenotype as well. And I find that the moment we fix those, the patient feels so much better. I had a patient who couldn't even really walk from his car into the office. He was so fatigued, tired, weak. But once we identified his toxins in his body and got rid of them, he came running into the office about 3 months later, feeling absolutely exhilarated. So I think that the toxicities from the environment, particularly mold, as a cardiologist, I'm just getting into this, but I'm finding more and more of it. If they don't already have it in their sinuses or in their gut, they're exposed from home, because you know that 7 out of 10 homes have mold, because they've either had water damage or some sort of black mold or some mustiness in their house, and they can smell it. We have a problem because we brought water into the homes, into piping, and now we're going to get water damage. So take a deep history, you'll find out, yes, I lived in a certain place that was very damp and very musty for 2-3 years, and then shortly after that, all my problems started. I'm having all these myriad of inflammatory symptoms right now. So we do want to identify them, and they are treatable. So it's not like you just are trying to identify them and say that, okay, I've identified it. No, they are treatable. And the way my approach against is an anti-inflammatory lifestyle, anti-inflammatory environment, anti-inflammatory diet, because your body does have the ability to get rid of these toxins. This includes heavy metals. See, nobody wants to talk about this, but it's everywhere. The water you drank this morning has mercury in it. The water you drank this morning also has birth control pills in it. There are estrogen disrupting compounds everywhere. Are they not causing inflammation in the body? Yes, they are. So all these plasticizers, all these hormones in the environment, they all have to be fixed before the patient's inflammatory condition gets. So it's a very deep dive. It's a difficult thing to do, because traditionally all we've done is said, okay, you want a prevention program? Great. Here's a statin, go home. That's it. And better make sure you take that statin, okay? Otherwise, I'm going to fire you. And that's been what everyone's doing. But it's much deeper than that. It's much, much deeper than that.
Before we move away from this part, I want to make sure we go a bit deeper into treatment, because for me, it seems like there's two different aspects to this, where we want to clean up the environment and be preventative from this stuff coming in and toxifying us. But if we're somebody who is, say, middle-aged, we've accumulated a lot of this stuff. You mentioned going anti-inflammatory with diet and lifestyle and the body taking care of it. But somebody like your firefighter who's really on the far end of this and they're really toxic, are there certain protocols, detoxes, saunas, things you can recommend for people to purge this out of the body to at least get back to a baseline?
Wonderful, 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 wonderful. Very tough, very tough. So does the body have its innate mechanisms to detoxify itself? It does, because nature built into us detoxification programs. And which is the biggest detoxification organ you got? It's your liver. You got to take care of the liver. But look, we're really destroying it by eating garbage, and we're eating all the sugar, and we're getting a fatty liver. A fatty liver cannot detoxify you. So you got to get rid of the fatty liver. So you got to work on your diet. You got to get rid of all the carbs. You got to get rid of sugar. You got to get rid of all additives and everything. You got to fix the leaky gut. And you fix the leaky, and I'll talk about how I do all this. Then your liver will say, okay, now I can get on and do the job that I was supposed to be doing. And to help the liver even more, I will give some supplements. For example, it's so strange that patients who are having fatty liver, and I was giving them N-acetylcysteine, and I was giving them alpha-lipoic acid and astaxanthin. These are 3 supplements that I was giving all my patients who had a fatty liver. And this is before I did a deep dive into the metabolic endotoxemia from leaky gut. And I found that they got better in many ways. And it's because their liver got better, and therefore they were also able to detoxify themselves. Had I done tests on them before, I'm sure they would have lots of toxins. But slowly, they definitely got better because their liver got better. Because N-acetylcysteine is a precursor to the body's natural antioxidant, which is glutathione. So I give them simple supplements to take: alpha-lipoic acid, N-acetylcysteine, astaxanthin, milk thistle, for example. These have been shown to actually improve liver function and its liver's ability to detoxify these chemicals. So when they come in, instead of overwhelming the liver and causing localized fibrosis and fattiness of the liver, it is able to now have the enzyme systems that will detoxify these things and get rid of them in your bile and then out in your stools. Some patients require what is known as a binder. A binder is something like activated charcoal. And what it does, it binds these toxins and also makes sure that those coming out from the bile are not going to recirculate back into your own circulation. So depending on the load and which organism, I might give them a binder. And that will get rid of some of these toxins from their body as far as the liver is concerned. The next big organ is the kidney. So you make sure they're extremely well hydrated. See, these are simple things, but they work. Make sure that the kidney function is best. So get rid of nephrotoxins, no drugs that affect the kidney. Drink plenty water, and they got to drink plenty water, and that will help the kidneys also to detoxify itself. Because remember, when we do the testing on toxins, we're doing it on the urine because that's where they all end up and they come out. So you make sure kidney functions good. The next one is skin. And you already mentioned that. You mentioned sauna. So why I'm a big fan of sauna? I love sauna. I'm going to tell you a few things about sauna. A big study that came out of Finland, which demonstrated that those people with severe coronary disease who did sauna, they had regular sauna. They didn't have infrared. They did regular sauna. Those who did sauna 3 times a week had a 40 to 50% reduction in sudden cardiac death rates. Survival. I mean, if I had a drug that could do that, it would be a bestseller. Those who did it 5 days a week had a 60% reduction in sudden cardiac death rates. And these articles have come out. Of course, nobody talks about it. I don't see it on the news because it's not glorious. So they don't run with it. But this means that there's something that sauna is doing. So some people say, okay, it heats you up and therefore your heart rate goes up by 30%. So it's like doing a low-level exercise. Maybe. But another reason is it's detoxifying you because we know that toxins come out in your skin. We know that. That's a fact. You sweat a lot, it comes out of your skin. So you must sweat. So these days I use infrared sauna on these patients because it's a little easier for them. They can buy their own little machine. They put it in their house and just sweat away. Sweat away. And do it at least minimum 3 times a week, preferably 5 times a week. And they must sweat. Even a hot tub, when you sit in a hot tub, does detoxify you. Get that temperature high, you get vasodilation. But there are other benefits from all this. And we haven't talked about this yet. Evoking the body's own repair mechanism is evoking the vagus nerve. You have to evoke the vagus nerve because your biggest help is not only you. You got to hack nature's own repair process and enhance it. So I think that the vagus nerve also gets stimulated when you do sauna. So I love sauna for that reason. And one more thing I need to tell you is that sauna has been shown to liberate stem cells from your bone marrow that actually repair the endothelial cells. So those progenitor cells, the levels go up like crazy. So I think sauna is very good for that reason. And of course, that's another big reason why I do fasting, because we didn't even talk much about fasting today, but fasting has to become your fundamental way of life. It's not fasting like, no. It's that's just the way you live. And we can talk about that later if you like. But fasting is amazing. But infrared sauna for detoxification, fasting. Listen, there are so many different mechanisms by which one can not only live longer, but live healthier. And you can come across all these different inflammatory pathways. And it's the endocrine, it's the liver, it's the leaky gut, it's the toxins, it's the metals, it's lifestyle. But there's one thing that touches all the mechanisms and improves them all, and that's fasting. Fasting improves you metabolically. If it detoxifies you, improves your microbiome, because your microbiome is completely reset by fasting, because all those bad guys die within the first 8 hours of fasting, and just resets your whole gut. And what is the number one way you can release stem cells in your body?
Fasting?
Fasting, 300% increase in the release of stem cells, your own stem cells. Not only that, they're yours, they know where to go, and the residence rates is very high. That means they go where the repair needs to be. Fasting.
How long do we have to go to get that benefit?
You got to get to the point of autophagy. Autophagy will usually occur on the average patient at about 36 hours. On the average patient. Now, if you've been doing some time-restricted feeding, like I eat once a day, and on weekends I'll have 2 meals, sometimes 3 meals. Gradually, the point at which I started making ketones went from 24 hours to 20 hours to 18 hours. And now I start making ketones at about 16 hours. So I really deplete all my glucose from my liver and my muscles very early, and I start making ketones. At that point, I'm going to get a lot of stem cell mobilization. So we all mobilize stem cells, even in our day-to-day lives, but you accentuate it more by fasting. And it's when you really get into some degree of ketogenesis that you really start mobilizing your fat cells. We are all supposed to become a little bit ketogenic, as I've said on many of my talks before. Every now and then we should become ketogenic. Every now and then means, listen, once a week, you got to do a more prolonged fast, which means 24-hour fast or a 36-hour fast once a week. The rest of the time, you should do time-restricted feeding because that fits in with the way our body was made. Our body was not made to eat every 6 or 8 hours. And when you do this, it's a little hard in the beginning, but gradually, you start making, you turn on the machinery. You're getting what we call metabolic flexibility. The glucose is going to drive your mitochondria crazy. You're going to get reactive oxygen species production. So you get a lot of inflammation. 2 people, this one's eating a lot of glucose all the time. He's going to be more inflammatory. And we've done that. We've tested and we've talked about that so many times. This one is hardly eating any carbs and any sugars. His metabolism is mostly dependent on fat metabolism. And by the way, fat metabolism is amazing. What it does to the endothelium also, those studies have been done. You need that flexibility. You put things away into your fat, you need to take it out. It's not a one-way street. And by the way, why am I talking about the fat so much? Because your fat stores are not just fat. They're also full of toxin. Because a lot of the toxins and heavy metals are in your fat. So, when I make patients lose a lot of weight in my clinic here, I tell them that the metals are going to be coming out. So I got to not only make you fast to do this and your fat is all coming off, but I got to also make you a better detoxification machine. That's why I'm giving you these supplements for your liver. That's why I'm telling you to cut down your alcohol. That's why I'm telling you to fix your gut as well and change your diet and improve all that, because I want your liver to be good, because all those boys that were stored away are all coming out now. And people who don't do that, they feel sick when they start losing a lot of fat. So you got to take care of that as well. But the point is that when you have this type of metabolic flexibility, it's anti-inflammatory. There's less inflammation when you are producing some ketones. So you need to produce ketones every now and then. It's the time of the body when, because your insulin levels are low, you can move the fat. When your insulin levels are low, you can have autophagy. What is autophagy? Autophagy is when all those cellular debris that's in your cells get turned over because the body needs to become more efficient. But what becomes more efficient is your mitochondria. And remember I said earlier on that all comes down to mitochondrial health. If there's one thing you want to be very clear about today, is that all these things affect mitochondria. They are mitochondrial toxins. When the mitochondria gets toxic, they produce a lot of reactive oxygen species along the electron chain, and they produce low ATP. So you have a bad battery, that's what's going on. You're making too much smoke coming out from that electron chain, and you're not making enough ATP. So this whole machinery is to make your mitochondria better. Fasting gives you mitophagy. The best way to improve mitochondrial function is to do fasting. And you look, just ask my patient, how do you feel? Oh my gosh, I feel fantastic when I'm fasting, because he's got mitophagy and he's got autophagy. So you start doing more and more autophagy earlier in your fast than later in your fast. It has to be a lifestyle. You just have to periodically become ketotic. You just have to do it. You just have to do it. And my patients, I've taught them how to become ketogenic through fasting. And most of my patients, I tell them to do 18-6 every day. Every day. That should just be your lifestyle. 18-6. That means for 18 hours you are fasting, 6 hours you got the time to eat. And then, depending on who you are and what you need, like, okay, I told you my calcium score is 0. Why do I need to do this? Because I want to stay healthy. I need my reparative processes. So I do this. But let's say you have diabetes and you're obese. Then you do 18-6. But then I also will tell you, okay, you've done this, fair. Now I want a 3-day water fast from you because you weigh too much. You need to lose 45 pounds. And the way you're going to do this is you're going to give me a 3-day water fast. So what's so good about that? Look, when you lose the fat in a fast, it's all coming out from your viscera and all the inflammatory markers go down. But the biggest change is not that. The biggest change is when you break your fast and you start eating again. Now, who's eating? That body is totally different from before. Because you did the fast, your body, how it's going to handle food and calories is not the same as before. So now, let's say you did go out and eat that sandwich or a candy bar. Your insulin levels are so much lower that you will probably produce less insulin and you will not gain that weight even though you cheated. Because that fast changed you, at least for the short term. That means you changed your metabolism usually changes for about a week. You do a fast, and for at least 1 week, your whole body is now different. The way it reacts to calories and whether it's going to partition away the calories or not. Because your insulin levels are so low, you become insulin sensitive. And these studies have been done over and over and over again. We've done these studies and we know that. So if you look at weight loss programs in people who did intermittent fasting versus those who did caloric restriction, totally different metabolism. So it's the fasting that makes you change your insulin production and your sensitivity. So I'm very much into all these modalities because fasting touches on toxicity and detoxification, weight loss, fatty liver, inflammatory markers, sleep apnea, high blood pressure. So what does high insulin do? Vasoconstriction, nitric oxide depletion, you get high blood pressure. I've said this many times to my patients, there's no such thing as idiopathic hypertension. Hypertension is either because you have no nitric oxide, and the commonest reason is you have too much insulin in your body, or you have sleep apnea that has not been diagnosed. Number 1 and number 2. There's a few more at the bottom. But hypertension doesn't mean that you're going to be on blood pressure medicines forever. You have a metabolic derangement. That's why you have high blood pressure. So when you start fasting, your insulin levels come down, and guess what happens to the blood pressure? It's gone. My blood pressure is gone. So I see that just about every week where the patients come to me and say, can I get off this blood pressure medicine? My blood pressure is only 95 now. Boom, take them off the blood pressure medicine because their insulin levels have come down. So cardiovascular benefits of fasting, sauna, very good. Other things that you can do, we touched about the vagus nerve. So why am I interested in the vagus nerve? Because that's how the body repairs itself, restores its physiology, reproduces, repairs. It's all done through the vagus nerve. So when your gut is so diseased, the vagus nerve dysfunctions because the vagus nerve supplies your gut. So the enteric nervous system, which is as big or maybe even bigger than your brain in terms of the neurons, they get affected because all those endings there in the gut are all inflamed and they're getting these messages from the leaky gut. They are so overwhelmed by your lymphoid tissues that are in your gut, and most of your immune system is in your gut. Now the enteric nervous system doesn't work very well. So your vagus nerve doesn't work very well. So what I tell patients is that your vagus nerve not working well is working against you. You need to get your vagus nerve working better. So you got to fix the gut. Then there's vagus exercises that I tell them to do. And I give them high doses of fish oil, which repairs the vagus nerve as well. And the vagus nerve exercises are very simple. And people say, oh, yes, there's Dr. J. He's telling the patients to breathe, prolonged expiration. Why is he doing all this? Oh, it's too much about meditation. No, it's not. It's evoking your body's own physiology. When you do the vagal exercises, your heart rate comes down, your blood pressure comes down, your platelets become less jittery. Oh, platelets again. Oh, excuse me? We already talked about how jittery your platelets are when you're going to get a heart attack, right? Right? So your platelets pacify. Have those tests all been done? Of course they've been done. Your mental state and your vagus nerve is going to determine whether your platelets are going to degranulate or not. How? Because the ends of your vagus nerve release acetylcholine. Acetylcholine then goes to all these mast cells and other cells in your body, including the platelets, and sets the level at which they will degranulate. Vagus nerve means it will take a lot for that platelet now to degranulate and clot. Those studies have been done. For example, I'll give a very quick study. This was done in Johns Hopkins, where they took the medical students and they put an arterial line in them. And they gave the test exam. And they were measuring platelet reactivity through a refractometer to see how easily they clot. And as they went through the pages, it was easy. The platelets were fine. There was nothing happening. Then all of a sudden, they got a page where they didn't know what the answers were because they were never taught that stuff. And suddenly their stress levels went up. And guess what happened to the platelets? They went crazy. I mean, we have so much. I mean, I can talk about these types of things about the mind-body connection and your emotions for hours, and maybe we'll do it one day. But basically, there's a big connection between your thoughts, your emotions, and your body's physiology. So in a detox program, in an anti-inflammatory lifestyle, you cannot omit mind-body medicine. You have to evoke that. And the vagal nerve is part of that because we know the vagus nerve has rostral connections to the forebrain as well. You cannot leave out sleep. I tell patients how to breathe, breathing exercises, breathe in, and how to go into silence. I teach them how to go into silence. That is anti-inflammatory. Because then you're not sending those messages to those platelets. So there is no message. You're in silence. The silence is mental, internal silence. So I teach my patients how to do that. I teach it to them for two reasons. One is that, and secondly, when they take their attention away from a thought and bring it back to their breathing, that ability to put their focus, their attention, their consciousness back here and bring it away from that thought gives them willpower. The gym exercises are different from the mind exercises. The mind exercises are your ability to focus where you want it to focus so that you don't get constantly bombarded with thoughts of the past or thoughts of the future. Instead, you control where you want your thoughts to be. And when you do that, stress levels go down. That's my approach to stress management. So that's another thing that I want to develop that in a much bigger way in my practice and everywhere else. That we are bombarded all the time, and we are obsessing about the future, and we regurgitating the past all the time, and we don't have the ability or the tool to get out of that. And I want to teach people this technique because when you do that, now you put your attention where you want it to be because you've been practicing to bring it back here to that feeling of the breath going in and out. So people say, Dr. J, this is not cardiology. No, it's fundamental cardiology. It is. It's fundamental cardiology because it drastically reduces your sympathetic stimulation and you increase your parasympathetic. And I'll give you an example of where I use it the most here. Is I use it especially in young people who come in with tachycardia, rapid heart rate, palpitations all the time, fainting all the time. And I teach them these techniques and they come back saying they feel so much better. They don't need ablation, SVT ablation. And so we use it a lot here in our office. So the breathing is important. your ability to put your focus where you want it to be is an anti-inflammatory approach as well.
You have a number of videos giving exercises on your YouTube channel, which we'll link up. But let's give a few different exercises, somebody that wants to take this on for the vagus nerve. And how often would somebody want to do this?
Okay, I'll answer this last part first. So you just ran away from the tiger, the saber-toothed tiger. You just ran away. And it was a quick sprint. And this leads up to something about exercise. You did a quick sprint and you hid behind the rock. And as soon as the tiger went away, now you're just breathing normally. And your breathing pattern changes and you're doing prolonged expiration now. Just you're sighing and you're all comfortable and everything else. So how often should it happen? After each sympathetic burst. Today, our lifestyle is sympathetic all the time. It's go, 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 go all the time. So we're just not getting even time to sit down and evoke that parasympathetic response, that rest and relaxation response. So the answer to your question, the short answer, we should be doing it at least twice a day. And the studies do demonstrate that doing this type of inner silence twice a day for only 15 minutes in the morning and 15 minutes in the evening does translate to lowering blood pressure, lowering the heart rate. Are the studies being done for all the other parameters? No, I can't tell you that your interleukin-6 levels are going to come down because those studies have not been done. But I can tell you that it probably does help, but I don't have that data to support it right now. So the answer is at least twice a day. And in between, also, you should be consciously aware of your breathing because we're always holding our breath instead of breathing out. And even when I'm driving, I make a conscious effort that I breathe in to the count of 4 and I breathe out to the count of 8. I do that consciously throughout the day. I do more prolonged expiration because the prolonged expiration stimulates my vagus nerve. Your heart rate variability, which is a marked predictor of cardiovascular survival, and the level at which you trigger arrhythmias, the heart rate variability improves. Heart rate variability is something you can do on your watch and see what your heart rate variability is. It's just that I think that technology is fantastic. It's just that people haven't been taught how useful it is, how powerful it is. And you can increase your heart rate variability by consciously looking at how you're breathing and do it throughout the day. 2 times you should be doing 15 minutes, total silence. You got to do that. And also, for those who have the worst problems, I tell them, first thing in the morning, you wake up, splash your eyes with cold water. It evokes the diving reflex. My worst patients, I give them a little collar to wear, and it has a vagus nerve stimulator on it. So it just softly stimulates the vagus nerve. And a lady came to the office, and one of my assistants put it on her, and she like almost immediately felt so much better. But the point is that I can hack the vagus nerve. Then gargling is where I had a patient who was having arrhythmias, and in arrhythmias, SVT, she was having too much sympathetic, so you're getting a very rapid heart rate, SVT. And we do the Valsalva to break it, right? That's the breathing stuff that stimulates the vagus nerve. It didn't work. So she saw my video. So she took some water and gargled it. And every time she had SVT, it stopped when she gargled it because you're also stimulating that. And humming is fantastic because when you hum, you do that. So singing, people should sing more. People should hum more. People should, the yoga postures that we do, those are amazing. And I'll tell you why I tell them to do that is because when you want to go into silence, you can't be aware of the pain in your ankle or your knees. So you need some degree of flexibility and your joints need to be good so that you can sit quietly and not be thinking about, oh my God, my back is hurting, my butt is hurting or whatever, So when you do these yoga exercises, they do help you to basically sit and be quiet with no bodily distraction. That's why I don't tell them you got to sit cross-legged. You just sit in your chair. You can do it on your couch. Just be comfortable. Shut your eyes and get into that silence. And it's all part of my anti-inflammatory pathways that I want to teach people. It's a comprehensive program.
Couple more things I want to make sure we get to before we close. I know we're over time already, but coming back to LDL.
Yeah.
We know that in general, it's not the culprit. It's the small dents that is the problem. We were going through a list, and I just want to make sure if there was anything else that we forgot to mention in that realm. Things that create small dents out of LDL, making it problematic.
There are a few congenital conditions that you're born with, but that's very rare. And the reason I didn't mention that is because many people say, oh, I was just born with that small dents. No, it's not the case. No, basically we covered them, right? They're all acquired, and they're acquired from the diet and toxins in our body and the deranged metabolism of our body, such as insulin and sugars that cause the small dense molecules. You see, I just want to throw this out to you. When you glycate a molecule, like hemoglobin, that becomes hemoglobin A1C, it's glycated. Oh, it's high, it's running 6.9. You're glycating every protein in your body. So every enzyme in your body is glycated, including your LDL. So obviously, things are not going to work properly because everything's glycated. So the point there is that we want to make sure that all our cellular functions are good. One of the reasons why heat makes for better physiology is it releases what is known as heat shock proteins. The heat shock proteins brought on by heat go throughout the body and they fix the three-dimensional configuration of all the cells and the proteins. It repairs all the proteins through heat shock protein production. So that's another mechanism by which sauna really helps you. So our physiology affects not just one part. It's not if you have a bad LDL, you have bad just about everything in your body. Everything else is also out. It is not right. Yeah.
Okay, so last piece, diet. And this ties in with the fasting piece. We haven't really gone deep into this. But obviously, insulin has come up and we want to keep that low. So when it comes to prevention and keeping the heart healthy, what diet is best?
Great question. If you already have coronary artery disease, I'm going to be asking you to look at a blood test to look for sensitivities to food. You need to eat what you're not sensitive to, and you must do that blood test. There are two types of food sensitivities that I'm very concerned about. The first one is the major food that you're not responding well to. It may be wheat or it may be something else. The secondary food sensitivity problems are because the first one was there that allowed other foods to get in, and now your body gets exposed to those and produces IgG against those. So the food sensitivity is important. If eating certain foods does make you feel bad, you should get your food sensitivity test done. So as far as eating is concerned, stay away from the foods that you are sensitive to. That's rule number one. If you don't know that and you have coronary artery disease and if you feel that you have inflammation, my general rule is cut out wheat. 8 out of 10 patients without any blood tests, if they just cut out wheat from their diet, they feel better. And it's got to do a lot of things. It's not just that that person had wheat sensitivity problems or wheat germ gluten problem. It's because the wheat today is different as well. This is dwarf variety wheat. It's totally different from the wheat our forefathers ate. Then many of these people will go to Europe and they're able to eat sourdough bread and baguettes over there and they don't have any problems. So first thing is stay away from wheat if you already have coronary artery disease or if you already have inflammation or if you have any type of abnormality or if you're obese. You should stay away from wheat. The next thing is that people always ask me about the sugars. Of course, we've beaten that horse. About carnivore diet and vegetables. Which one should you be on? I don't restrict meat at all. My problem with meat is just that if you have the regular meat, it's going to have too much omega-6 in it because they're all fed on corn. I want grass-finished red meat. It is the most nutrient-dense food you can possibly have. Organ food is also very good. So liver is very good for you. Organic chicken is fine. Wild caught salmon is fine. So I'm not a vegetarian, and I don't advocate that either. Low fat food, low fat this, low fat that, that's all nonsense. You need the fats, but you need good fats. The good fats are the fats that naturally come with the food. For example, the grass-finished cow, that's fine. All the fats that are in it are going to be okay. The chicken needs to be organic. That's fine also. The vegetable seed oils must be obviously omitted. All processed foods should be avoided. So anything made in a factory, forget it. Anything that's got a barcode on it, anything that comes in a package, don't eat it because that's all man-made. Vegetables, you should eat vegetables. I want to say something about vegetables. Vegetables are actually medicinal. They have phytonutrients and other things that feed your microbiome. So you need vegetables. You need fiber also. Now, people say that how come carnivores get fiber? Yes, because the cartilage and other things are fiber in them also. There's soluble fiber there as well. So that's why I'm not too worried about the patients who eat mostly carnivore food. That's fine. As long as they're eating the right food, I have no problem with that whatsoever. The vegetables, I like all cruciferous vegetables. I don't like my starchy vegetables, so no potatoes. If you're going to eat potatoes and rice, this is what I tell them. You are otherwise pretty good, pretty healthy. You need to eat those starches if you really have to. You cook them, cool them, refrigerate them overnight, eat them the next day. Now they will become resistant starch. So my diet is, you can have some resistant starch, you can have some vegetables, you can have meats, you can eat meat 3 times a week, 4 times a week. I have no problem with all that. My problem is that eat the right food in a short period of time, interspersed with fasting, where your body can repair itself 18 hours a day, 16 hours a day. That's the way to, because then you're hormonally also going to give the body a chance to respond with the best insulin sensitivity and other modalities. And you can detoxify yourself as well. So my diet is very simple. If you're allergic to that food, don't eat it. Eat occasionally. Eat real food. It has to be alive. The food has to be alive. Don't eat dead food. Why are we eating dead food? For what? You don't get any, in my old days, I used to talk about the energy frequency of the food, the vibration of the food, that this food is alive, it's still vibrating. Now, have I proven that? No. There are no tools that I have right now to put the food into a machine and say its vibrational frequency is very high. I guess it can be done. But basically, if it's going to rot, if it's going to go bad, eat it. Because it's got nature's energy built into it. And so it's very simple. For breakfast, most of the time we don't even have breakfast, but no processed foods. You can eat eggs, you can eat spinach with it, and you can have tea, coffee, my drinks. Oh, by the way, talking about diet, since you asked me about diet, do I like smoothies and do I like the machine-made drinks? Generally, no. Because even though you're putting your vegetables and your fruits into a mixer and you're spinning it at high frequency, you're breaking up all that fiber. And that fiber is not going to be as useful as if you had masticated it with your mouth. So again, eating the right foods in the right manner. Don't drink your food. You should be eating your food. You should be masticating it so that by the time it gets down into your gut, your body has to work on digesting it and it gets released slowly into your bloodstream so that your body is not overwhelmed with a huge stimulation of your K cells, which will cause a huge stimulation of your insulin levels. That's just totally unnatural. Unnatural way of eating. Don't eat unnatural foods. Don't eat it in an unnatural way. So don't get rid of all those. Now, the only people I do allow to have some smoothies and stuff like that is people who have no teeth. I'll let them have it. And there are a few patients who I'll allow some juicing on once in a while, vegetable juices. I'll let them have a little bit of that. If I feel that they're nutritionally very, very deficient, then I'll say, okay, for the next 1 month, I'll let you do some green juicing. But it's individual. Generally, eat it. There is a machine now called the masticator. And I like that machine. Take your vegetables, put it. Now, fruits. I got to say something about fruit. In general, fruit should be consumed in season and mostly in the fall because it has so much fructose in it that it changes, it makes you insulin resistant and makes you therefore store calories. So you plump up before winter comes, before you go into hibernation, but of course you don't go into hibernation. So we have a problem. And we eat fruit throughout the year. One of the biggest problems we have is consuming too much fruit. So I tell my patients, you can have half a fruit a day. That's it. No more than half a fruit a day. Too many calories. So vegetables, some fruit. Then variety of vegetables. Lots and lots of herbs, different colors. Put herbs into it. Each one classifies itself as one vegetable. You must have a variety of herbs. I told you when I started, vegetables are medicinal. That's what vegetables are for. All these different herbs, they're all medicinal. They have specific effects on specific microbiome. Most of them are for your microbiome, by the way. They're not even for you. They're for your microbiome. This is the important thing, to understand that you're a symbiotic relation between you and your microbiome. Stop eating for yourself. You should be eating for you and your microbiome, starting today. What am I doing with this food? Is it going to feed my microbiome? If it's got phytonutrients in it, all these blueberries and colors and everything else, you think it's for you? It's not for you. It's for your microbiome. See, it's a different thought. Now you have the right microbiome and you're a symbiotic relationship. Almost 50% of the micronutrients that are floating around in your body is not what you consumed. It's what your microbiome made, pooped out, released into you, and got into your body. Typical example is short-chain fatty acids. So short-chain fatty acids, you can measure this. On the blood test that I usually do on my patients and the stool samples, you can measure short-chain fatty acids. If they are running very low, you have a huge problem because the microorganisms that are supposed to be making short-chain fatty acids are missing in your gut. And that's why your short-chain fatty acid levels are so low. And these are such important molecules. They are anti-inflammatory molecules. Right there, I'm telling you, they're anti-inflammatory. They are a fantastic source of energy. They reduce your reactive oxygen species. Lots of data on short-chain fatty acids we can go into. They're very anti-inflammatory. And they're made by who? They're made by your gut bacteria. So in part of your nutrition is eating for your microbiome. You need to eat more fiber. The difference between processed food and regular food is that your regular food has fiber in it. Don't slither it and don't kill the fiber. Eat lots of fiber. In every meal, you must have lots of fiber. I use inulin plus FOS, which is my powder, I love because I can't get enough fiber in my diet. I just can't. So I add that every day. So because of my lifestyle and everything else. So lots of fiber and all the phytonutrients, the different colors and everything, it's all for your microbiome. Don't kill your microbiome. How? Don't drink alcohol. Alcohol kills the microbiome. Basically, you're taking hand lotion full of alcohol and putting it into your belly, right? And you expect your microbiome to be good? No. Alcohol will kill your microbiome. Plasticizers, synthetic chemicals, sweeteners, colorings, emulsifiers, all terrible. Sorbate, polysorbate, all these emulsifiers. Absolutely horrible for the gut because your microbiome will deal with it because they have 4 million genes. You only have 22,000 genes. So they will accommodate just about anything that comes down, but the products of the metabolism will not be good for you. So you should not be consuming anything unnatural. They'll deal with it, but then you'll have the consequences of it.
All right, final question. I know you got to go here, but I think this will be a good way to wrap up. And I asked you something similar, but I still need clarity. Say we have somebody right now, middle-aged, they have some plaque, they have some clots. It sounds like most people will have some of that going on. What is the best they're going to hope for, prognosis-wise, with that, if they adopt what we're talking about today?
You will live with your plaque, but you will not die from your plaque. You can live with plaque. Just because you got coronary calcium and your score, by the way, I've got patients now for 7-8 years that I've been following with calcium scores of 4,000. They're still doing fine. So long as you follow an anti-inflammatory lifestyle, anti-inflammatory environment, anti-inflammatory diet, 3 things, then you can live with your plaque and not die from it. You'll die of something else. So yes, the prognosis is good. You got to do this program. Yes, you're going to need some supplements. Yes, you're going to need some antiplatelet agents. Yes, you're going to need to do some dieting, lifestyle changes, circadian rhythm disorders, sleep. You need to do the whole package. Bottom line is, yes, you can live with it. Yes, you can, and you can live a long time with it. Just because you have a calcium score that's high doesn't mean you're going to die. It was the graveyard of what happened then. It's not the graveyard of what's happening now. Now, it's burnt off. It's done. Your inflammatory markers are low. Your LDL particles are nice. Your HDL is high. Your triglycerides are nice and low. Your blood pressure is nice and low. Your CRP level is nice and low. Your MMP levels are nice and low. We didn't even talk about all this, but these are chemicals that you can actually measure. Your interleukin-6 levels are nice and low. You can measure those too. See, you can measure these things. And it's important to do that because you need to know that you're going to be okay. Because otherwise you're going to be living in sympathetic tone all the time, worried, oh, I'm going to die tomorrow. You need peace of mind also to live long. So you can live with that plaque and have peace of mind as well. Get your test done. Get your peace of mind so that you can sleep well and have a great physiology.
All right, Dr. J, this is a great place to leave it. Incredible conversation. Really enjoyed this. We're going to link up your YouTube channel, your website, everything in the show notes. Thank you.
Thanks a lot, Jesse. It was my pleasure. Thank you.
Now that you're done, you're going to want to stick around here and catch this other incredible episode. You don't want to miss it. I'll see you over there.
No, there's nothing else that tracks with LDL cholesterol because it's not a real number. It's a fictitious number. It's obtained by something called the Friedewald calculation. The LDL cholesterol reducing franchise, statin drugs, PCSK9 drugs, all that stuff pay.